Down like this, grab onto the ankle, bend this up like this, bring it over here like this, stabilize the opposite side, press down. So that causes you any discomfort, right? If it's an older person, I would say, as I'm performing this test anywhere along the line that it causes problems or pain in your hip or elsewhere, please let me know. And I wouldn't rip the leg up, I would bring it up nice and slowly, and then I would just go like this. Okay? Okay, what's our next test? Scouring test. What are we looking for? Some type of a labral tear, right? Now, so what are we going to try to do with this labral tear? We're going to try to pick it up, right? We're going to look for like a clicking, clunking, painful clicking, right? Painful clunking, snapping. Wouldn't be slapping. What does it say? Clunking.
It says pain,
catching. And so we're going to bring this up, right? And we're going to put the hip into varying degrees of hip flexion, right? Varying degrees of flexion. We're also going to do what? Internal, external rotation, and what else? And we're going to do some adduction and abduction, right? And we're going to go through all these motions, visualizing our femoral head, right? And we're going to like ream that acetabulum out with that femoral head. That's what we're trying to do. See if there's any catching, anything inside there, any pain when they're doing that. And that's looking for labral tear, right? What's the next one? Anvil test. And we're looking pretty much for some type of, it could be a pathology, but pretty much it's geared more towards a fracture, right? It'll be pretty specific, and you're just going to just pound them along that kinetic chain, right? So the leg, we want to have it into flexion, into extension, full extension. You can even pick the leg up a little bit to make sure it's an extension, that you have that joint. And then you're going to really bop them on the bottom, just like this. And if they have any problems, fracture, the calcaneus, the tibia, femur, femur head, anywhere along that line, they're going to say yes, and they'll be able to point to where it's caused them problems. Okay? You have to give them a pretty good thump on that. Okay. Next. Trendelenburg. Now, if somebody has a positive Trendelenburg, you're going to know right when they come into your office how. The gait. They're going to exhibit that Trendelenburg gait. So whenever they're posting up on that bad side, by the way, the bad side is where they have the weak glutes, right? Whenever they post up on that, it's going to drop down like this. Because this is the bad side, right? In the test, I'm going to have you stand up if you would, please. And I'm going to have you stand with your back to here. You're facing this way, your back to the people. And not have them hold on, but get them close to something in case they feel like they're losing their balance, they want to grab onto something. So, not like a vase or something, but something stable. Okay, so let's just say this patient has problems on the right side, right? So we're going to have him post up on this right side, and we're going to have him pick up the left side, right? So when I tell you all your patient's problems are on the right, then you're going to say, wow, his problem's on the right. I better have him stand on that right foot for this. Don't forget. Okay. And so then you're just going to have him bend their knee and flex their hip is what you want to do. So flex this hip, bring your knee up. Thank you. Good. If it's bad, it's going to what? It's going to drop down because of those weak abductors on that side. Right? We got that? Cool. What's our next one? Craig's test. That's anteversion, retroversion. Let me have you lay face down if you will, please. We're going to bend the knee up. And by the way, we don't teach all the orthopedic tests that there are. We just try to give you some of the very common ones. It's a good idea to read through some of these more than just your notes. As you talk to people, come back. We're going to bring the patient's knee up, right? And retroversion and anteversion, that's like a congenital malformation, is the way the femur neck, etc., comes into that socket, right? So what we want to do is we want to palpate the greater trochanter, and we're going to bring that into a position where that greater trochanter we feel is most parallel to the floor, right? We're going to then look for a plumb line that's going to be dropped down, that's going to meet right here at the medial side of the knee, and we're going to measure this angle here. If that angle is greater than 25, right? Is that what Sousa said? That's a little different than everybody else. Sousa says greater than 25, that indicates what? Anteversion, right? If it's less than 12, is that his number, 12 to 25? And other sources say 8 to 15, though, isn't it? What does it say in your notes? 12 to 25. It doesn't say anything else?
You have right now 8 to 15.
8 to 15, okay. So, I don't know what to tell you, but, you know, Sousa's a good reference text for chiropractic, so I think if you understand the mechanism, they may tell you the angle is decreased, the angle is increased, they may not give you a number, and so that would help you to know what's going on there, right? So watch how they word the question, think about what they're asking you, and then it's also very good to know what's going on with your patient. You know what I mean? You know, because say they're toeing in a little bit, and we think, well, maybe that could be an IN ilium, right? Or excuse me, an EX ilium. So they're toeing in, you're thinking EX ilium, and say, well, maybe they have some anteversion going on there. You know what I mean? So there's all different kinds of things that we need to look for and be aware of that could be going on with our patient, instead of just making assumptions from one or two small details. But look at the details, because the more of them that you can gather together, the better you're going to do. Right? What's our next one?
Quadriceps Q angle.
Quadriceps, the Q angle. Let me have you stand up for a minute. And what are we looking for with the Q angle? You're looking from the tibial tuberosity, right? Coming up to the patella, and you're going to have a line coming up there. Then you're going to have a line coming from the ASIS, and it's going down to the patella, and we're going to look for that angle. And I don't remember what normal is on that. Women have a greater Q angle though, right? What are the angles?
Greater than 15 degrees.
Yes.
Oh, it doesn't differentiate between men and women, but women do have a greater Q angle. Okay? So greater than 15 degrees means that they could be having a problem with patellar tracking. Is that right? You want to strengthen like the VMO, I think, right? So, and if they have tracking problems, that can lead to patellofemoral arthralgia, right? Which, the longer it's in there, and it keeps grinding, keeps scraping, and so on, what does it lead to? When you get that blistering underneath there, chondromalacia patella, right? You start to get that little ulcering underneath there, etc. Okay, what's next? Adduction stress. Would you lay down here again? Now let's just, in fact, let's just bring this over here. Have you sit down. Have an adduction stress, varus and valgus stress. We can do this with the patient seated. You can do it with the patient laying down. It might be easier to just show this seated. I don't care how you do it on your test. But if we're going to be doing, what was the first one? Abduction stress is the same as what? Valgus stress. And we're testing for what? Medial collateral ligament, because we're going to put pressure right along here, right? So we'd say, well, we do this test bilaterally, beginning with a good side. You have to get a baseline. So we're going to say he's having trouble with his left knee, and maybe he's had some type of injury where his knee was belted this direction, right? So, and I mean hit that direction. Okay, so we're going to bring this up like this. Stabilize here. I like to get the leg up like this. Pull it over with my elbow, using your forearm as the fulcrum here. My hand, this arm here is the fulcrum, and I'm going to do stress. I'm going to be looking for any type of signs of laxity. The patient will tell me if there's any pain in there when you're doing it. Right? Pain, laxity, different grades of sprain, right? Sprain of the medial collateral. So if he has a problem with the lateral collateral, then we're going to have to do an adduction stress, which would be a varus stress, right? And so now we're going to have to, we'll say he has problems on the right knee. We'll bring this one up like this. Take out the slack on the knee this way as I'm bringing my elbow into my body and pushing this way. We're looking for this to bow out, right? and that would be your add a deduction stress, which would be Varus stress for lateral collateral ligament. Yes.
Foot direction on that for the rotation?
Oh, thank you. No, you want to do it in full extension, and then you want to do it, what, 30 degrees of flexion? Okay, both of them. So yeah, I forgot that. So we're going to come up, we're going to do it like this, and then if that doesn't work, we're going to bend it up a little bit and do it this way. Okay. Don't forget that. Don't forget that. Do both of them. Okay. Is that okay? Any questions on that? So that would be for your add and abduction stress. You're going to be stressing it twice. Remember that. Okay. What's our next test?
Distraction.
Apley's distraction. And that is, again, for these ligaments, right? So when you're examining your patient, it's always good to have more than one test. Don't just say, okay, that they're having problems with their left knee, so we're going to stand on the patient's left side. Of course, we'll do it on the bilaterally, beginning with the good side, right? I don't want you guys to lose 5 points for nothing. Okay? Now, when we're doing this, we have to hold the patient's, let this be real relaxed here. So we're going to bring this up, right? And we're going to have our knee turn medially, right? And, excuse me, not our knee, the heel goes medially. So we're doing external rotation of the leg, right? You got to remember that. When I'm doing the external rotation of the leg, I'm testing for which collateral ligament? Medial. Very good. Restore the bone back to normal, the leg back to normal, and then let it relax. Okay, when we're going to check the lateral, we're again going to distract. We're going to turn into internal rotation, right? The heel is going laterally, so we're testing for the lateral collateral ligament. Again, restore back to neutral. Let it out. Okay? Is compression the next one? So when we're going to do compression, we want to grab hold of the patient this way. I like to come over top this way, push down, turn the heel. Again, we're doing external rotation of the leg, and we're checking the medial meniscus, right, the way the heel is going. And we're going to compress down, turn the heel laterally for lateral meniscus, right? So, what's that?
I was just saying that.
Yeah, what is the next one?
Bounce home.
Bounce home. Can you lay on your back, please? Bounce home, we're looking for some reason why that leg is not going to fully extend. And we do know that when someone is having problems with the meniscus, they're usually going to have what? What's the key thing they're having when they have a meniscus problem that Susan talked about?
Locking.
Painful locking, right? Usually it's some kind of lock. So if we're going to be testing, you can put this leg down first, Matt. If we're going to be testing, we want to make sure that this knee is going to be able to go through its full range of motion. If he has any type of problems with the meniscus, the leg will probably not fully extend, right? You won't get that nice end feel that you're used to, that bony lock. Another thing that can cause that is what? Joint mice. And you can get joint mice with someone has pretty advanced blood. Can you get it with RA? That I don't know. With what? Don't want to slam it too much. But you're going to have you have any trouble with this knee or anything? No. Okay, just let your leg be real relaxed. We're going to bring this up. We're just going to let it drop. We want that knee to fully lock. Okay? If we do this and it doesn't fully lock, then we're going to assume there's some type of a problem and they're keeping it from doing that. Meniscus is something we can do that joint mice need.
McMurray.
McMurray's test is also for meniscus, and we changed this up the way we're doing McMurray's, and I know that I've told you guys about this. So we're going to do varying, first we're going to bring the hip and the knee up to 90 degrees. We're going to do internal rotation, and we're going to add some valgus stress while we're doing it, and then we're going to straighten this down, right? Then we're going to bring it back up, and we're going to add some Varus stress in here, and we're going to do it again, right? That is still with the heel pointed lateral, all right, for lateral meniscus. Then we're going to do the same thing with the heel, the leg in external rotation with the heel medial, and we're going to do varus and valgus stress. In fact, I think Susan says when you bring it up here, you're just supposed to bring it up and just rotate the foot first. Does it say anything in your notes about that?
Flex the knee, then you do the knee at 90 degrees. Wait.
I think they even start the test just here. And then they start doing it with the different stresses on it. Okay? Just remember, do it with the varus and valgus stress with the heel medial and the heel lateral. And the direction that the heel is going is the meniscus you're testing. We used to say that if you're doing the lateral meniscus, then you want to do it with the valgus stressed and the heel pointed laterally because you're compressing the meniscus on this side. But they're saying no, they want it done medial, varus and valgus stress with the heel lateral, varus and valgus stress with the heel medial. Does it say that in your notes? Is that clear or no? Oh, Thessaly's test. Thessaly, I'm going to have you stand up. Thessaly's is also for what? So I'm going to just have you stand right here, face me, and then I'm going to have you. This patient's having problems with their left knee, so I'm going to have you hold my hand here. And what we're going to do is I'm going to just have you bend. How many degrees? About 5? 5, 10? 5? And then I'm going to just have you twist like that on that. Good. Does that cause you any pain? Okay, then I'm going to have you go down even further. And now twist again. Any problems with that? Okay. Thessaly test for meniscus. High positive predictive value on that test. Okay, next test.
Patellar grinding test.
Patellar grinding. Let me have you lay back. Clarke's test. And I think this is condylation patella, isn't it? Okay, now all of these tests should be done on skin. You know, we're just doing them, we fly through them, we really shouldn't be doing these. We should be looking at every one of these joints on every one of these tests. We should be doing that, but we're not. And so that's setting a real bad example. If you help me next quarter, we'll have you wear a little tutu. Okay. Okay. So we're going to have the patient's legs straight down. We're going to say he's having problems with his left knee. Would you put your legs, just extend them down, lay flat down on the table. We're going to milk this down, right? And we're going to hold it, right? And we're going to have the patient then contract their quads. And when they do that, you're going to see if they can maintain that contraction, right? Or if they can't do that, or if it causes severe pain. Is that what it is? Pain, or just can't hold the contraction? Chondromalacia patella. Is that right? If you ever have a patient with chondromalacia patella, you always got to check the Q angle. You always got to think about strengthening the BMO, etc. Okay, it's all types of things necessary for straightening that person. What's the next one? Is it Fouchet's?
Yep.
Okay, so the patient's having problems again under their knee, maybe some type of lesion under the kneecap. Is this also chondromalacia patella? Patellofemoral dysfunction, some problems could be a tracking problem, which could lead to patellofemoral arthralgia, which could lead to chondromalacia patella, and so on, right? So we're gonna just crunch that kneecap right down in there, and you're gonna say, does that cause you any pain? No. If it does, you say, where's it causing you pain? Oh, don't forget that. And then if that doesn't cause them any pain, what are we gonna do? We're gonna grind it back and forth, right? And you're going to say, does that hurt? Does that cause you any? No. Okay, good. Okay, that's Fouchet. Ballottement test. We're going to be milking down the fluid. You definitely want to be looking at the patient's knee on all of these. Don't forget. And that tells us there's some type of effusion or buildup of edema or fluid underneath the kneecap, right? So we're going to milk that all down. We're going to be pressing the kneecap in, and we're going to see if it has this floating mechanism coming out, not just a normal motion. So it'd be a very good idea to do your bilaterals. Get it. That way you'll see the difference.
Drawer test?
Drawer. We're going to bring the patient's leg up. Again, I want you to palpate. Remember we were talking about this. If you palpate right along this tibial plateau here, you can easily find the joint right here between. And this is a good idea because when we start adjusting these in extra spinal to help you find your contact points. You know, differentiating between the top of the tibia and the bottom of the patella is sometimes a little bit difficult. So if you palpate in here, you'll find the kneecap, of course, you'll find the patellar tendon, and then you'll go into these little grooves, and then you'll just move right into the space between the joints. And so remember that. I know we did that last time, so do it again today. What we want to do is stabilize the patient. You can hold them down like this with your knee. You can sit down on the foot, whatever it is. You want everything at 90 degrees. Palpate right along here, and you should feel that moving just a little bit. You'll see maybe a little bit of give, but if it translates 6 millimeters, is that what it is? And you see that stair-stepping effect? That's a problem with the anterior cruciate ligament, right? You can text the posterior cruciate ligament, same mechanism. We're going to push through, and we're going to see if there's any problem with that posterior cruciate ligament, right? We're looking for translation of that joint. And any of you go on YouTube and look at any of these? I told you to do that. You see some interesting things taking place. So, Lachman's is very, very similar. Sometimes, I'm going to have you move your head up just a little bit that way. We're going to have the leg down. Instead of at 90, we're going to move it down to about 30 degrees, right? And we're going to do the same thing, stabilize, and we're going to just pull this way. That's one way to do it. Another way to do it is to hold on this way and just go back and forth with the knee, pulling the pulling the femur and pushing the tibia, and then vice versa, pulling the tibia and pushing the femur this way. And we're looking for that translation. And again, that is for anterior cruciate ligament. I don't care which way you do it. Know how to do both.
You mean you don't care which way we do it?
I don't care if you just do it to 30 and yank it like this. That's okay. Okay. Lateral pivot shift. Again, we're looking for the anterior cruciate ligament, right?
Yes.
And we're going to internally rotate the foot. A lot of these, hopefully you guys have gone through, and a lot of these tests are very similar, right? We're going to add a valgus stress. We're going to internally rotate. On this one, you're going to bring everything up to, what is it, about 45 degrees?
30.
About 30 degrees. And then what we're going to do is we're going to add our valgus stress, palpating right behind the fibular head. And we're going to then just bend the knee, right? And we're going to look for that to shift. And what's shifting is the whole tibia. The reason why I'm palpating up behind the fibular head, you'll see it, but then the fibular, that's attached to the tibia, and that's why you'll see that. And that'll all clunk backwards. And if you look on YouTube on some of the sites and you see that, you really know what they're talking about. Again, ACL tear, right? Anything else besides ACL on that?
Generally, grade 3 tear, also injury, possible, I guess, also injury to the posterior lateral capsule.
Okay.
LCL and ITB.
Say again?
LCL and ITB.
Okay. What's the LCL? What's the ITB? And so you just follow up on some of that. If you think it's an IT band, problem, then you're...
Noble compression.
Noble's compression, and that's for what? IT band, right? A lot of people have problems with IT band. They're having trouble with their knee, check the IT band. I can tell you, taking care of knees, that if the knee does not need adjustment, even if it does, you always want to check the muscles that are articulating. IT band is a very big one that's involved with that. So we're going to bring the patient's leg up like this, right? I'm going to pivot to the superior. I'm going to put I'm going to put pressure right over the lateral condyle, right, of the femur. Now it is coming down. It's coming down onto the tibia. That's why they call it the IT band. But we can put pressure just proximal or right over that femoral condyle, right? So don't think it's ending at the femur, because it's not. And we're going to just bend this down. And while we're holding pressure on there, we get down to about 30 degrees, and it causes a lot of pain. Then you say to the patient, where does that hurt, etc. And usually if they have trouble, any type of problem with the IT band, you can go up to the TFL, right, and you'll find trigger points in there. And usually any type of soft tissue work, release, whatever, Graston work, all that helps that person with that. I don't know if they do ultrasound on that or not. Do you know anything about Slocums? Slocums. This is for what? Anterior.
Medial rotation of stability.
Oh man, Man, we didn't even get further. Anterior medial rotational instability, anterior lateral rotational instability. And there's a lot of things involved, and we've written them in there, so please, I just want you to tell me anterior lateral rotational instability, anterior medial, and turn the foot the right way. So if you're doing internal rotation, that's anterior lateral. Stabilize, yank it out this way. If it's anterior medial, stabilize, yank it out that way. Right? Anterior lateral rotation instability. Sorry we ran out of time. We can do the last couple tomorrow. We have our quiz tomorrow.